Imagine your body's plumbing
Yep.
is controlled by this delicate self-sealing rubber valve.
Right.
It's designed to flex, adapt, and just hold back pressure effortlessly, you know?
Like a perfect seal.
Exactly. Now imagine a daily habit that silently, over years, turns that dynamic rubber valve into a rigid, dried-out plastic straw.
A structure that is completely incapable of stopping leaks.
Right. And today, we are not talking about your lungs. We are talking about something taking place deep within the pelvic floor, something that fundamentally alters the microscopic plumbing of the human body.
It really does.
So in our deep dive today, we're taking a massive stack of medical journals, urology clinic data, cross-sectional studies, and we're going to look at how chronic smoking physically chokes the microvascular blood supply to a tiny but entirely vital muscle, the urethral sphincter.
Yeah, and by choking that blood supply, this habit aggressively worsens a condition called stress urinary incontinence, or SUI. We are essentially looking at a masterclass in how a systemic habit impacts a highly localized mechanical function in the body. I mean, the data reveals a biological chain reaction that most people, even many medical professionals, honestly, don't immediately connect.
Yeah, so if you're listening to this and thinking, well, I just have a bad cough, that's why things leak, we're going to completely dismantle that assumption today.
We really are.
We'll establish the mechanics of what doctors call a lead pipe urethra. We'll explore the cellular starvation caused by vascular resistance and look at the surprising, almost science fiction ways human tissue physically mutates under oxygen stress.
It gets pretty wild.
It does. Okay, let's unpack this. Because if we're going to figure out how a cigarette breaks the valve, we first need to know how the valve is supposed to work.
Well, stress urinary incontinence is medically defined as the involuntary leakage of urine during physical activities that increase intra-abdominal pressure.
So everyday stuff.
Yeah, exactly.
Yeah.
Everyday downward forces. Sneezing, laughing, jumping, or, lifting a heavy box.
Right.
And for decades, the historical view in medicine was that stress incontinence was almost purely an issue of anatomical shifting.
Like things just moving out of place.
Right. Doctors looked at the hypermobility of the vaginal wall, assuming that the physical support structures had just sagged over time, or maybe after childbirth, pulling the plumbing out of alignment.
Meaning the plumbing itself was fine, it was just hanging at the wrong angle?
Yeah, that was the operating theory for a really long time. What's fascinating here is that the modern urological understanding brings us to a severe subcategory of SUI called intrinsic sphincter deficiency, or ISD.
Intrinsic meaning the problem is inside the tissue itself.
Precisely. This concept focuses on the fact that the failure is intrinsic. It is independent of whether the vaginal wall is mobile or not. The hardware of the sphincter itself is breaking down from the inside out.
Okay, so to picture this, let's look at the normal anatomy for a second. A healthy human has two main mechanisms working together to keep urine in the bladder, right?
Yep. Two main layers of defense.
First, you have the internal sphincter. And this is made of smooth muscle. It operates entirely subconsciously. It's like the baseline guard that keeps you dry while you sleep.
Well, you don't even think about it.
Then, just below that, you have the external sphincter, which is made of skeletal muscle. That one is under your voluntary control. So when you consciously decide to, hold it in while waiting in a long line for a restroom, that external sphincter is doing the heavy lifting.
And they operate as a tandem system to maintain what urologists call coaptation.
Coaptation.
Yeah, coaptation is the normal closing pressure. It's the surface tension and elasticity that allows the walls of the urethra to rest perfectly flat against each other, which creates a watertight seal.
So they just naturally suction together.
Exactly. But in a patient with intrinsic sphincter deficiency, that coaptation is lost. The mucosal integrity degrades. The actual mass of the sphincter muscle wastes away.
Wow.
And the sources describe the most severe form of this deficiency using incredibly vivid clinical terms. They call it a stovepipe patulous or lead pipe urethra.
A lead pipe urethra. Man, that gives you an immediate visual.
It really does.
Because a healthy urethra is that self-sealing rubber valve we talked about. It pinches shut tightly on its own, it can stretch, it can flex. But a urethra with ISD has turned into this dried-out, stiff pipe.
Right, the internal pinch is totally gone.
So liquid just falls right through the hollow center under the slightest bit of gravitational or abdominal pressure.
And the clinical reality of a lead pipe urethra is devastating for a person's quality of life because the leakage is constant. It requires very little pressure to trigger because the sphincter has lost all of its resting tone.
I have to admit, I'm struggling to connect the dots here, though.
How so?
Well, we are talking about inhaling tobacco smoke into the lungs. How on earth does a habit focused on the respiratory system end up rotting the material of a tiny muscular valve down in the pelvic floor? On the surface, those two things feel miles apart.
I know, it seems like a leap.
Yeah.
But the bridge between the lungs and the pelvic floor is the cardiovascular system, specifically the micro blood vessels. Nicotine, along with thousands of other chemical compounds and toxins found in cigarette smoke, are powerful vasoconstrictors.
So they shrink blood vessels.
Right. When they enter the bloodstream, they force blood vessels to narrow. But chronic exposure does something much worse than just temporary narrowing. It causes persistent endothelial injury.
Let's break down endothelial injury for a second. The endothelium is the inner lining of your blood vessels, right?
Yes.
It's supposed to be like the smooth Teflon coating on a frying pan, allowing blood to glide through effortlessly.
That is a perfect way to visualize it. Nicotine and the oxidative stress from smoking essentially scratch up that Teflon coating.
Yikes.
Yeah, they introduce chronic inflammation. So the smooth lining becomes damaged and jagged, which triggers the body to constantly try to heal it, leading to a buildup of plaque and scar tissue.
So over time, the physical diameter of these microscopic vessels shrinks, and the walls become incredibly stiff.
Exactly.
Okay, but even if the blood vessels are getting scratched up and stiff, is the actual smoke traveling down into the pelvic region to do this damage?
Well,
Because I think a lot of people would assume that if a smoker is leaking urine, it's strictly because they have a terrible smoker's cough. Like the mechanical strain of hacking your lungs out seems like the obvious reason a valve would eventually give way, right?
sure, and the mechanical strain of a cough is a massive factor, which we will definitely analyze shortly. But the foundation is crumbling long before the mechanical strain even hits.
Really?
Yeah. When you inhale tobacco smoke, the toxins don't just stay in the lungs, they cross into the bloodstream. And then the heart pumps that toxic, oxygen-depleted blood absolutely everywhere in the body, including the tiny capillaries feeding the pelvic floor.
So it's systemic.
It is, but there is also a secondary delivery method that is unique to the urological system,
Oh, wait. The filtration system.
the kidneys.
Exactly that.
Hmm.
Your kidneys are designed to filter toxins out of the blood and excrete them into your urine.
So, a chronic smoker's kidneys are constantly filtering out nicotine metabolites, carcinogens, and heavy metals and dumping them straight into the bladder.
Oh, wow. So that highly toxic urine just sits in the bladder for hours at a time, directly bathing the pelvic vessels, the bladder wall, and the urethral lining in localized chemical irritants.
It's a brutal double exposure.
The toxins are arriving via the systemic bloodstream, and they are pooling directly in the plumbing itself. That's intense. And the data we have on how this affects blood flow is wild.
It really is clear-cut.
One of our sources pulls from a study on patients undergoing a prostate procedure called HOLIP. Let's unpack this study because the methodology here really proves what is physically happening down there.
Yeah, so HOLEP stands for holmium laser enucleation of the prostate. It is a surgical treatment for men with enlarged prostates.
Right.
And researchers realized they had a unique opportunity. They had a group of patients, some were smokers and some were non-smokers, who were already undergoing a procedure in the pelvic region.
So they could just look while they were in there.
Pretty much. They decided to use transrectal color Doppler ultrasounds to look directly at the pelvic blood vessels and measure the real-time blood flow in these two groups.
Which is so cool. Color Doppler is essentially like a weather radar, right? But instead of tracking storm clouds moving across a map, it tracks the velocity and direction of red blood cells moving through a vessel.
The underlying physics are very similar, yeah. And the researchers focused on two highly specific metrics. The first is the resistive index, or RI.
Okay, all right.
This measures the resistance that blood encounters as it tries to flow through the vessel during a heartbeat. If the vessels are healthy and wide open, the resistance is low.
Makes sense.
The second metric is color pixel intensity, or CPI. This measures tissue perfusion. Essentially, what volume of blood is successfully saturating the surrounding tissue.
Okay, so looking at the numbers, I'm guessing the smoker's weather radar did not look good.
Not at all. The data showed a stark contrast. The chronic smokers had a significantly higher resistive index and a dramatically lower color pixel intensity compared to the non-smokers.
So the blood is hitting a physical wall of resistance because the vessels are scarred and narrow.
Right.
And because the blood can't get through, the CPI drops, meaning the actual tissue of the pelvic floor is starving.
We are looking at tremendous vascular resistance, leading to what clinicians call organ hypoperfusion,
Hypoperfusion.
which is simply the medical term for tissue starvation. The microvascular supply is choked, meaning the urethral sphincter is being chronically starved of oxygen and vital nutrients.
Which brings us to the next logical question. We know the plumbing is starved of oxygen, but how do we get from oxygen starvation to that rigid lead pipe urethra?
That's the real core of the structural issue.
Because if a plant is starved of water, it just wilts and dies.
Right.
What does a lack of oxygen actually do to the living flesh of a sphincter to turn it into a stiff plastic straw?
Well, to understand the physical mutation of the tissue, we have to look at cellular biology and the body's emergency response systems. Oxygen isn't just fuel for energy. It is an absolute requirement for normal tissue maintenance, cell regeneration, and wound healing. When tissues become hypoxic, which is the clinical term for oxygen-starved, the cells don't just passively die, they panic.
They panic.
Yes. This hypoxia triggers a very specific molecular distress signal. It activates a protein complex called the hypoxia-inducible factor 1, or HIF1.
HIF1, it's like a biological fire alarm going off inside the cell, screaming that the oxygen supply has been cut.
The mechanics of HIF1 are really fascinating. Under normal, oxygen-rich conditions, the body constantly produces HIF1 and immediately degrades it. It is kept in check.
So it's always there, just waiting.
Exactly.
Right.
But the moment oxygen levels plummet, that degradation stops. The HIF1 proteins accumulate, travel into the nucleus of the cell, and act as a transcription factor. They start flipping genetic switches.
And what do these switches do?
Well, one of the main switches they flip turns on profibrotic genes.
Profibrotic genes, meaning they instruct the local cells, the fibroblasts, to start aggressively laying down excess connective tissue.
Right.
They trigger fibrosis.
Right. Fibrosis is the abnormal, excessive accumulation of extracellular matrix elements.
Basically scar tissue.
In plain terms, yes, it is the mass overproduction of scar tissue. The body is trying to stabilize a dying environment by throwing down heavy, disorganized structural fibers.
Here's where it gets really interesting. If we think about that HIF1 fibrosis process, it's essentially a desperate, panicked construction crew.
I like that analogy.
Right. Their normal job is to build and maintain this highly flexible, delicate rubber valve, our urethral sphincter.
Yeah.
But the supply chain is cut off. They have no oxygen. The fire alarm is ringing constantly.
Yeah.
So instead of building delicate rubber, they just start pouring cheap, rigid concrete everywhere to try and hold the structure together. And because the alarm won't stop ringing, they pour way too much of it.
Exactly.
And the result is a structure that is heavily scarred, rigidly locked in place, and completely unable to flex or pinch shut.
The cells are trading dynamic functionality for raw, rigid stability. The tissue loses its muscular grip entirely. And we actually have stark microscopic data on just how much of this quote-unquote cheap concrete gets poured, thanks to a remarkable study in our sources that analyzed foreskin tissue.
Wait, foreskin tissue. Walk us through how a study on foreskin connects back to the internal urethral sphincter.
It connects through the field of reconstructive urology. Surgeons frequently use foreskin tissue to create what are called fasciocutaneous flaps.
Okay, so skin grafts.
Basically, yes. These are grafts where they take a section of skin, along with the underlying connective tissue and blood supply, and use it to surgically patch or rebuild a damaged urethra.
Got it.
But surgical teams were noticing a deeply troubling trend. These reconstructive flap surgeries were failing at an alarmingly high rate in patients who were chronic smokers. The grafted tissue was simply dying or necrosing after being transplanted.
So they put the smoker's foreskin tissue under an electron microscope to figure out why the patches were failing. What did the pathology show?
The pathology revealed a massive structural mutation. When they compared the tissue of chronic smokers to non-smokers, the smokers presented with a 42.5% increase in elastic system fibers.
Okay, I have to pause you there because that sounds completely counterintuitive.
Wow.
A 42.5% increase in elastic fibers.
I know it sounds backwards.
If we are talking about a sphincter that needs to stretch and pinch, wouldn't having more elastic fibers make it more flexible and functional? Why does more elasticity equal a rigid lead pipe?
It is a brilliant paradox, and it comes down to the difference between organized structure and chaotic overproduction.
Okay, explain that.
For elastic tissue to function properly, the fibers like elastin need to be arranged in neat, parallel lines. Much like the suspension cables on a bridge, they need space to stretch and recoil smoothly.
Right, they need organization.
But in a chronic smoker, the hypoxia causes a condition called elastosis. The body dumps a massive, disorganized tangle of elastic fibers into the extracellular matrix.
So instead of neatly arranged suspension cables, it's like taking a million rubber bands, throwing them into a blender, and then packing them tightly into a tiny space. They
Exactly.
might technically be made of rubber, but as a dense, chaotic knot, they can't stretch at all.
That is the exact mechanism of the failure. The sheer volume and chaotic cross-linking of these fibers cause abnormal tissue extensibility. It jams the mechanics of the tissue.
Wow.
The tissue cannot stretch naturally, and more importantly, it cannot snap back into place. This pathological overproduction fundamentally degrades the natural, functional elasticity required for coaptation.
It's not a functional stretch at all. It's a floppy, stiff, dysfunctional mutation that completely ruins the tissue's ability to maintain a seal.
When you combine this loss of normal tissue elastic properties with the scarred submucosal layers we discussed and the incredibly poor venous blood flow, it perfectly explains the evolution of intrinsic sphincter deficiency.
The hardware hasn't just sagged out of place like they used to think.
No, it has been structurally mutated by chronic oxygen starvation.
This paints an incredibly grim, highly mechanical picture of the pelvic floor for a chronic smoker. I mean, we have microvascular ischemia literally choking the blood vessel shut. We have the HIF-1 alarm triggering the pouring of cheap concrete.
Yep.
And we have a mutated fibrotic sphincter jammed with tangled fibers that has turned into a rigid lead pipe. But to fully understand stress urinary incontinence in these patients, we have to look at the other forces at play. Because the lead pipe isn't operating in a vacuum, right?
Right. Urologists frequently refer to this scenario as a perfect storm for SUI because smokers are almost universally hit with a compounding triple threat.
A triple threat. Okay, we have thoroughly covered the first threat, the weakened fibrotic sphincter caused by microvascular ischemia. The gate is permanently broken open. What's the second threat?
The second threat introduces a completely different mechanism of failure, and this one is driven directly by the chemical properties of nicotine.
So nicotine isn't just a vasoconstrictor. It operates as a direct chemical irritant to the bladder itself.
Exactly. The bladder is a muscular sac called the detrusor muscle. When high concentrations of nicotine and its metabolites pool in the urine, they chemically irritate the detrusor muscle.
Because the kidneys dump them there.
Right. And this irritation causes the muscle to spasm involuntarily. This manifests as symptoms of overactive bladder, or OAB.
Oh, man.
Yeah, the central nervous system gets chaotic signals, making the smoker feel a sudden violent urge to urinate, regardless of how much liquid is actually in the bladder.
So you have a faulty, rigid valve that is incapable of holding liquid back. And ED, you have a bladder that is spontaneously, aggressively squeezing itself, trying to push liquid out.
It's a bad combination.
That alone is a disaster for continence.
It is, but then you add the final, highly destructive piece of the perfect storm.
The cough.
The mechanical battering ram of the chronic smoker's cough. We cannot understate the physical physics of a heavy cough. When a person coughs, the diaphragm violently contracts, compressing the entire abdominal cavity.
This creates a massive spike in intra-abdominal pressure.
Huge spike.
It's essentially taking a water balloon and squeezing it with both hands as hard as you can.
That intense pressure is transferred directly down into the pelvis, forcing urine against the urethral sphincter.
And in a healthy person, the rubber valve flexes, pinches tighter in response to the pressure, and holds the seal.
Right. But for the chronic smoker, you have this repeated, violent mechanical pressure slamming against a mutated, rigid lead pipe that no longer has the strength, the healthy elastic suspension cables, or the muscular grip to hold it back.
It is a compounding cascade of mechanical and biological failures. I mean, the blood supply starves the valve, the nicotine makes the bladder squeeze spontaneously, and the cough repeatedly smashes whatever urine is left right through the broken gate.
It's the perfect storm.
And the sheer scale of the demographic dealing with these exact mechanisms is staggering. The sources point out that over 33 million men and women in the United States are affected by urinary incontinence.
And the vascular destruction we are analyzing does not isolate itself to the urethra. The data notes that up to 30 million American men face erectile dysfunction, and the underlying mechanism is nearly identical.
Wait, really? Erectile dysfunction is the same mechanism?
Absolutely. Penile erections require massive, rapid vasodilation. The blood vessels must expand to allow a huge influx of blood.
Right.
If the pelvic blood vessels are scarred shut, stiffened by endothelial injury, and incapable of expanding due to smoking-induced hypoxia, the physiological process of an erection simply fails.
Because the vessels literally can't open up.
Exactly. The systemic nature of smoking means no pelvic organ is spared from the oxygen starvation.
So what does this all mean for the listener? I think this forces a complete paradigm shift in how we view urinary and pelvic floor issues.
Definitely.
Because so often in our culture, we brush off a little leakage or pelvic weakness as just a passive, inevitable part of getting older or, the unavoidable toll of having children.
Right. It's just seen as normal wear and tear.
But looking at the biological reality of HIF1, vascular resistance, and elastic mutation, these aren't just passive signs of a biological clock winding down. These are active structural injuries being dealt to the pelvic floor, cigarette by cigarette.
If we connect this to the bigger picture, the silver lining within all this data is that it provides a highly empowering, actionable narrative.
Because it's a modifiable lifestyle factor.
Exactly. Because this is fundamentally a vascular and tissue level problem driven by the continuous intake of specific toxins, it means quitting smoking is a highly effective, conservative behavioral treatment.
That makes total sense.
Yeah.
By stopping the intake of nicotine, carbon monoxide, and oxidative chemicals, you halt the continuous microvascular degradation.
You allow the endothelium to stop fighting chronic inflammation.
You stop the biological fire alarm, you cut the HIF1 signal, and you tell that panicked construction crew to stop pouring chaotic, cheap concrete into your tissues.
The body has an incredible capacity to stabilize once the ischemic assault stops. Halting the progression of intrinsic sphincter deficiency before the tissue reaches that absolute lead pipe stage is entirely possible through smoking cessation.
Wow. To synthesize the journey we've taken through the plumbing today, smoking severely constricts blood flow and damages the delicate Teflon lining of your pelvic vessels.
Yep.
That vascular resistance starves the pelvic floor and the urethral sphincter of oxygen. That oxygen starvation triggers a cellular panic, flipping genes that cause massive fibrosis and abnormal structural mutations like that pengled 42.5% increase in non-functional elastic fibers.
The blender of rubber bands.
Exactly. Ultimately, the living tissue degrades, turning a dynamic valve into a rigid lead pipe that is entirely unable to withstand the violent mechanical pressure of a chronic smoker's cough.
It really bridges the gap between inhaling a puff of smoke and the mechanical structural failure of a sphincter inches away from the floor.
It totally changes how you look at the human machine. We so often view our anatomy as this fixed architectural blueprint that we are born with, just a static structure that slowly, inevitably wears down over decades.
Right, but it's constantly rebuilding based on what we expose it to.
Exactly. But knowing that a daily habit like inhaling tobacco smoke can fundamentally rewrite the microscopic composition of your tissues, literally turning flexible living muscle into rigid, scarred, unusable bands, leaves you with a profound question. If a cigarette can mutate the plumbing of your pelvic floor, how many other invisible architectural changes are our daily habits building inside of us right now?